Alrighty, next speaker this morning is pharmacist Ghada Abdallah. She is the CEO of Park Consulting and Staffing Services. And I'll let her explain as to what she's going to be speaking about. Thank you.
Thank you. So I'm going to take you back to 1991. It's a crisp spring day. My family and I, and all my cousins, my aunts and uncles, and all the neighbors were gathered on the front lawn of my uncle's house. Right in front of my uncle's house. But we're not having a block party. We're actually watching my uncle's house go up into flames with my uncle trapped in the basement. By this time, the stairs have collapsed, and the firefighters are struggling to break the glass block window that is, for some reason, a lot of houses in the Midwest are built with these tiny windows that go to the basement. When they finally break out enough glass to get him through there, they have him hanging on to the steel frame, and there's still a lot of broken glass, and in the process of extracting him out through the window, and he's a larger guy, he ends up losing a few fingers. They get him out. His torso is all scratched and wounded and bloody, and his body's covered in soot. They throw him on the stretcher, wheel him over to the ambulance, where he spends over a month in the ICU due to smoke inhalation. And that's not even the worst of it. Within a few weeks of being discharged from the hospital, my uncle was back on the street looking for his next fix. You see, what I didn't tell you was that drugs or alcohol or both had something to do with that fire. Now, how many of you here, and you don't have to share if you don't want to, how many of you have someone in your family or a friend who has struggled with a substance use disorder? Okay, thank you guys for sharing. This is a safe place for me, and I'm so glad that you're able to share as well. My family has had, unfortunately, more than our fair share of addiction. There we go. These are my cousins. These are 4 brothers. The second one in from the left is Billy. Unfortunately, we lost Billy in 2015 to a drug overdose. Drug overdose is the 3rd leading cause of death in the United States, and opioid overdose is the #1 leading cause of accidental death. 168 people die every single day from an opioid overdose. And 2/3 of the people who have reported misusing these drugs say that they got them from a friend or a family member, most often for free. Now, how are we going to break this cycle? What are we going to do? When we treat addiction as a temporary disease, like the common cold, like give it a month and it'll go away, treat people for a month, we're never going to achieve recovery and optimal treatment and recovery, lifelong recovery. But here's where we can begin. We really have to acknowledge that addiction is a chronic disease, maybe even like a terminal disease that will end someone's life if it's not treated swiftly, with urgency, and by wrapping our arms around the patient and their family. And I propose that we build interdisciplinary, diverse healthcare teams composed of healthcare professionals, law enforcement, social workers, anyone who touches the patient. Anyone on this circle here can be part of the team, but you don't have to start this big, okay? I know we talk a lot about interdisciplinary teams, but I propose we call this a life transformation team, because when you get these people together, you can really transform somebody's life, okay? And like I said, you don't have to start with all of these people on the interdisciplinary team. You can start small, like how I did. And I'm going to share with you a story of how I was able to start an interdisciplinary life transformation team at my pharmacy when I owned pharmacies in the Detroit area. So just a real quick poll. I did put this in the app. oops, I just kind of wanted to get an idea of who's here. In the app, there was a lot of pharmacists. Any nurses in the room? Yay, okay, great. Doctors? Awesome. Pharmacists? All right. Okay, guys, this is really for you. But everyone here, this is for everyone, guys, okay? Diversion investigators? Law enforcement? Okay, yeah, law enforcement. You guys are part of the team. Any social workers? Payers. Payers is a big one. Yay, thank you. Okay, awesome. Yeah. Okay, so I need to reintroduce myself. So I'm the CEO of Park Consulting and Staffing. Most recently, my firm was hired by the city of Detroit to design, implement, and staff their COVID vaccine mass vaccination clinic, where we vaccinated over 500,000 people. And we did that by forming a huge interdisciplinary team. We hired over 500 people. We hired nurses, pharmacists, doctors, EMS personnel. We even hired traffic control people. And we worked very closely with the city planners and the Detroit Police Department to have an extremely successful COVID vaccine drive. Before that, I owned 3 independent pharmacies in the Detroit area. And that's where I first experienced working on an interdisciplinary team. My pharmacies had a direct contract with hospice agencies, okay? And so hospice deals with death, okay? Death is a sacred time. It's a transition from this life to the next phase of our existence. And contrary to what you see in movies, death is a prolonged process. It's like a journey. It lasts weeks to days. Organ systems fail slowly, one after the other. And it's very hard for families to watch, especially the death rattle. And it doesn't matter if someone's dying from cancer or from drug addiction. Every person deserves to be treated with the utmost respect and dignity. Okay? I'm just going to read this quote real quick. I wish I could tell people how nice it can be to die of cancer. These surprising words were spoken to me recently by a woman who died peacefully a few days later. That's from a monumental book from 1969 called On Death and Dying. And it really set the tone for creating the hospice program that is in existence today. Okay, hospice dates back to the 17th century in France, but it wasn't until the 1960s, that you had your modern hospices appear in the United Kingdom. This book here had a major role in for the formation of the first hospices in the United States, like in Connecticut. 1974 is where we had our first one. Medicare and Medicaid started funding hospice by 1978, and then we finally had a fiscal law that put it in place in 1982. But it wasn't, yes, 1982. It wasn't until 2010 that Medicare and Medicaid, that the Affordable Care Act expanded access to hospice through private insurance, and that was Obamacare, or the Affordable Care Act. Can you imagine how hard it was to deal with the death of a loved one before that time? So we got, at Park Pharmacy, that was the name of my pharmacies, we had 3 locations. We got our first direct hospice contract in 2012, okay? I considered myself lucky to be sitting on a table, around the table with doctors, nurses, the social worker, the chaplain, nutrition, everyone who was involved in caring for the patient. And when the nurse would talk about her encounter with the patient from that week, I felt like I was in the patient's living room. You know, she would describe, maybe Mrs. Smith is having some swelling in her legs or edema, she's having trouble breathing, what should we do? And we would talk about all the non-pharmacological solutions that they had tried. As the pharmacist, I would go through her med list, and I would make a recommendation about maybe change the dose of the water pill, or maybe change the water pill altogether. And after a little bit of deliberation, we would finally decide on something, And I had my laptop with me so I could type the order right into the computer. It would get sent to my pharmacy immediately, where my staff was filling it and preparing the order. And oftentimes, before the meeting was over, because we would go through all the roster or half of the roster every week, before the meeting was over, the nurse would get a call saying, "Thanks for the medication." So my staff had already delivered it before our meeting was over. And I was so impressed, by our coordination and the humanity that we gave to each patient, that this experience really solidified my belief that we should do this for everyone who has a chronic disease that could potentially kill them, including addiction, okay? There's a lot of value with this hospice model. I want to talk to you a little bit about Billy. Billy was a charming kid. Everybody wanted to be his friend at school, even the teachers. But his addiction began at a young age with the diversion of legal pills. And when he could no longer get those pills legally through legitimate sources, he turned to the street for some heroin. And unfortunately, he overdosed on some heroin that was laced with an overwhelming amount of fentanyl. And at that time, fentanyl was still new. When I first heard about his death, my first reaction revealed something very troubling. I told my mom, well, at least Billy's mom doesn't have to deal with all his problems anymore. My mom said to me, "How could you say that? No mother should ever have to bury her son." She was right. Despite being a mother myself and an educated healthcare professional, I allowed stigma to cloud my empathy. If someone like me, who's an educated healthcare provider, could fall into this trap of judgment, can you imagine how pervasive these attitudes are in our society? In fact, 75% of people that were polled recently in the United States don't believe that addiction is a chronic medical disease. 65% of people said they don't want somebody with a substance use disorder marrying into their family. And 46% of people who are struggling with a substance use disorder reported feeling shame of their disease. Imagine somebody who has a cancer diagnosis feeling ashamed of their disease. Even though I had learned about addiction in school, like Maggie just told us in her previous presentation, we don't get nearly enough education in school to understand addiction, okay? Following Billy's death at a memorial service, a friend shared with me that her cousin had also passed away from a drug overdose. And we got our heads together and we said, this has to stop now. This is crazy. So we started approaching all the leaders of all the community centers and the houses of worship. And we asked them to speak about addiction to the families and their members at their weekly sermons or their weekly events. We also coordinated some town halls and really got a good dialogue going in the community. Now, at the time, our primary message was prevention. Because I didn't know, even as a healthcare professional, I didn't know how to lead people into recovery at the time. My first instinct was we have to prevent people from getting addicted in the first place, okay? I mean, we had lost Billy and my friend lost her cousin, and we didn't want this to happen to anyone else. So, and the reason I know that is because 85% of the people who enter treatment, any one of these treatment modalities listed here, they relapse within the first year. So that means only 10 to 15% of our treatment is effective within that first year, these treatment. I remember after one of the town halls, a lady got my cell phone number from somebody, and she called me, and she's like, "You're the lady, you're the pharmacist, you're the one who's talking about addiction in our community, and my son is struggling with addiction, and I don't know what to do, and I need your help desperately." And I told her, "Gosh, I'm really sorry. I wish I could help you. I just don't know where to tell you to go." Her son had Medicaid. They only covered a 30-day inpatient residential facility, 30-day residential facility. All the beds were full in Detroit at that time, and I didn't have anywhere to send her. It was really sad. And I really struggled when I heard myself telling her, I don't have anything to help you. Because I'm a healthcare professional, and it's my job to be able to lead people to health and recovery. So this was another revelatory moment for me, and I started to think about how can I change my practice to help people, because I do know that 75% of people eventually will lead who are struggling with a substance use disorder, will lead a full and productive life. They'll achieve lifelong recovery. So because of all the advocacy work that we were doing, I got appointed to the mental health board in the Detroit area, so it was for Detroit and the surrounding community. This is where I really learned a lot about about addiction, stigma, harm reduction, and I was able to lean into networks that I'd never been in before. I was able to talk to people who were in the recovery community and treating people. And that really allowed me to think about, how can I enter this community? How can I be part of these, how can I forge relationships with some of these different providers? So what ended up happening was we ended up meeting some addiction doctors. They were mostly primary care physicians, and many of them were people in recovery themselves, or maybe they had a family member who was struggling with addiction. And they were seeing substance use disorder patients 1 day a week, like on Thursdays. Thursdays was the most popular day. And they needed help. They had an overwhelming number of people requesting to be seen on that day that they couldn't manage everything, okay? And they didn't have enough MAs to administer the medication. They didn't have enough, maybe they didn't take the insurance. They had a few challenges in place. And it was only 1 day a week. So I said to myself, you know what? It's not that big of a risk. Let's do this. Let's figure out how we can make this happen. So what did we do? We started working with these doctors through collaborative practice agreements. Every state in the country has some type of wording around the collaborative practice agreements in their public health code, okay? There's different levels of regulation, and I'm in Michigan, and I'll talk about that in a little bit. But you have to really go back to your state board and look at the language that's written. It's very important. Using collaborative practice agreement laws that we had in place, we were able to implement this clinical use guideline of using extended release naltrexone in our pharmacy, okay? So what we did was, we also used medication-assisted treatment too. So, and this is, it's kind of complex, and I'm not here to talk about how you want to do this, but these resources are available to you online. What we did was, in addition to the primary care doctors, we also started meeting people from big treatment centers that didn't take any Medicaid. They were all commercial payers. But they had multiple centers across the state, and then they had the IOP, intensive outpatient group meetings that they would have also once a week, where they provided transportation from the IOP to our pharmacy where people could come and get their medication-assisted treatment. Medication-assisted treatment is like Suboxone, buprenorphine, even methadone is sometimes used, naltrexone. What we did, we also worked with, halfway homes, three-quarter homes, and there was a woman who was in recovery. She owned a cluster of homes in a neighborhood near our pharmacy. And part of the requirements that she set forth for people to be eligible to live in her homes, they were all recovery homes, was that they had to be adherent to their medication-assisted treatment, okay? She really believed in abstinence. She didn't mind if people were on Suboxone and getting weaned off and getting on naltrexone. She believed abstinence was the best form of recovery. But anyway, this is kind of complex because when you move somebody to an opioid, from an opioid to abstinence, you fall into this problem of, hey, they could start having withdrawal. Withdrawal is very uncomfortable. And it's actually one of the leading causes of people showing up in the emergency rooms all across the country. because they're experiencing symptoms of withdrawal. I had one patient tell me he was actually, unfortunately, he was addicted to benzodiazepines. He told me that withdrawal was the worst thing ever. He didn't wish on anyone else. And I had another woman tell me that it was worse than childbirth. So withdrawals are no joke, guys. So using the guidelines from the standing orders that we used in hospice, I started to think of that as a guide, and I talked to the doctor about why don't we create standing orders to help us deal with the symptoms of withdrawal for patients who are not very complex. They don't have any additional disease states besides the substance use disorder. They don't have any chronic medical conditions. So we started to oversee with a supervised withdrawal at home, okay? And this was a 7-day withdrawal from whatever opioid they were using until they became drug-free. Within those 7 days, they had to pass a drug test, and then they were able to get the long-acting injectable naltrexone. And I'm telling you, this was like kind of one of the most eye-opening things in my practice, because people would come to me later. I didn't give all the injections myself, but our pharmacists were trained to give the injections, and people would come to me and say, your program really turned my life around. They were now able to care for their children, where their children were previously with their, being taken care of by their grandchildren. Now they could keep a job, they could have a relationship with their significant other. It was really life-changing, life-transforming, right? During this withdrawal period, the 7-day period, we gave them access to a 24-hour number that they could call. And part of the agreement with the doctor was they would always be supervised by somebody. And we also had 24-hour access to the doctor. I actually had his cell phone. So the advantage to the doctor was, hey, we have pharmacy, he had a nurse on call, he had himself. He didn't have to go through the hassle of keeping these medications in stock at his office. He didn't have to worry about reimbursement issues. And they knew that our pharmacy, we had reimbursement in real time, our wait times are low. We had a special room in the pharmacy where we gave the injections and counseled patients on the service. And you know what, the idea of standing orders, it's not new. Most states have implemented a Narcan standing order, so to make Narcan very, very available, you can get Narcan anywhere now, basically, okay? It's like an over-the-counter. And we were lucky to be in Michigan. If you take a closer look at this, and I'll have the slides on the website in a couple of days, but if you take a closer look here, Michigan is only one of 4 states that's in white. And the white means that we have very loosely defined or no definition of what collaborative practice agreements can do. So with very little definition of what we can do, basically, you could do anything you wanted. The sky is open to you. And I know pharmacists and law enforcement like to define what can you do, but when you put too much definition on what can be done, you really limit your profession. By having very little regulatory burdens in Michigan, I felt like I was able to practice at the top of my license. The only things that are mentioned in our public health code is that the pharmacist has to work within their scope of practice and under the delegation of a physician. And we did all of that. And how did we do this? We worked very closely to develop these standing orders by having dinners and lunches with the doctors. My whole team and their whole team would all get together. Sometimes we would get the pharmaceutical companies to come and pay for dinner. I'm sure you guys have had that. After a few of these dinners, it was apparent that we were getting somewhere. We had a long dialogue. We kind of deliberated back and forth. And one day after these dinners, I come into the pharmacy, and Christy, one of my best pharmacists, says, Ghada, I got to show you this Google Sheet. Okay, so the night before, she had recorded everything on her phone, and she went home. She couldn't sleep, and she just went at it, and she just typed it all out, and she shows me what became our collaborative practice agreement. I sent it over to Dr. Fox, and the doctor that we were working with. I said, hey, what do you think of this? He said, this looks great. Let's just change this here, this, that, whatever. And then we did that. We implemented it. Then the woman from the recovery home approached us, and she said, hey, I'm working with Dr. Gupta down the street from you. I said, hey, doctor, she's like, can you talk to him? I want to do what you're doing with Dr. Fox. I said, okay, fine. I talked to Dr. Gupta. He said, oh, you're doing this with Dr. Fox? He and I go to the same country club, and actually, we run on the treadmills next to each other every morning. I'll talk to him about this and let you know. The next day, he was on board, and that's how we got the recovery home patients on board as well. So, I want to make the case for pharmacy. Pharmacists are the most accessible healthcare professional in the United States. Pharmacies have long hours, work located conveniently on all the major street corners, and we're one of the top trusted professionals in the polls when they do rankings. Pharmacists played a critical role during COVID-19. We vaccinated the majority of people in the United States, okay? And given that success and what we did, don't you think, if we could do that, if we could vaccinate almost everyone in the US, don't you think we could play a role in the opioid epidemic? COVID was a pandemic. The opioid crisis is an epidemic. And I think that pharmacists should be taking a more of a leadership role in addressing the opioid crisis. Medication-assisted treatment is the gold standard. It is first line. It should become more accessible. And pharmacists are the medication experts, so why aren't we playing a bigger role? And this isn't a new concept. The triad between the patient, the pharmacist, the physician, this goes back to ancient times, this idea of working together. Retail pharmacy is a key player in the healthcare industry. We might be facing some significant challenges right now. Last year, Rite Aid went bankrupt, unfortunately. Walgreens just recently sold themselves back to private equity for a small amount of the value that they were previously worth. But I still think that if we can align the financial incentives and allow these pharmacies to reassert a strong position in healthcare so that we can take the lead. Medication-assisted treatment is the first-line therapy for people and it's actually the most effective treatment to reduce overdose deaths. Because withdrawal is the biggest deterrent to recovery. People don't want to go through withdrawal. As soon as they start feeling that itch, they're back to their drug of choice, okay? Now, I already talked about there's many paths to recovery, and there are many schools of thought, especially if you go to AA meetings or NA meetings. Some people believe that only abstinence is true recovery, but I'm here to say that there are multiple roads to recovery. There's like 1 million roads to recover, however you get there. And MAT, medication assisted treatment, is just one way that we can do that. Okay, so when I was on the mental health board, I learned about all of this stuff. Prevention. We talked about education in the previous presentation. MAT, Suboxone, Methadone, Naltrexone, all of these things are ways you can get into recovery. We wouldn't be anywhere without our social workers and our counselors to provide, and our psychiatrists to help people create their new life, okay? They have to change the way that they live. We talked a little bit about case management and care management through some of those health professional recovery programs or the physician programs that are run by each state. Those are the most effective ways because people are held accountable, and Maggie spoke about this, and so did Christy yesterday. So I'm not going to spend too much time there, but that really is the most effective way because people are held accountable, and that is based on the aviation, the airline pilots, the way that they treat people. The way that the airline pilots do it is more strict than the way the healthcare professionals do it, but we use that as a guide for the physician and healthcare professional recovery programs that are linked to the state boards. And we definitely need the wraparound services for people, the peer recovery coaches, the housing and employment, the legal support, family education, the meetings, all the harm reduction strategies. All of these things, when you put them together, it really leads to a collaborative life transformation team. And I want to just tell you a quick story. When I was working for the mayor of Detroit, the mayor specifically asked us to hire people who were re-entering society from jail. And my director of HR kind of lost her mind. She said, Ghada, we are not doing that. Do you know how much liability That's going to be, I'm not going to let you do that. We had over 500 people already hired to run this mass vaccine clinic, but the mayor really wanted this. This was part of bringing Detroit back, right? And so we talked about it, we got legal involved, and ultimately we hired maybe 30, 40 people who were re-entering citizens, and we got them back to work. And that is the thing that I am most proud of from that whole project. It was amazing. It's an amazing feeling. And those people, they would come and talk to me. We ended up, they were doing traffic control or doing the stock room. We gave them education and skills, accountability. If they didn't have a ride, Detroit is really bad with public transport. One of our supervisors would pick them up from their halfway house, okay? It was incredible to be part of this transformation in their life. I was very happy about that. I'm sorry, okay, so let me go back, hang on. So the hospice program is unique to death, but it can be used as a guide. And it has been shown that it does save Medicare money, okay? There have been many studies to show that collaborative practice teams, interdisciplinary teams, whatever you want to call them, life transformation teams, they also save money too. And I'm just going to focus on the green box on the bottom. The implementation of collaborative care in Medicaid alone can save the program $15 billion per year. That's $15 billion. So where do we go from here? You know, how do we address this? What do we do to move forward? First of all, I talked about stigma. We really have to educate people. We talked about this in the previous session. Doing it in school. I mean, where else are you going to learn it? We have to do it in school, okay? And many of us are already practicing. Law enforcement does not get nearly enough education about this. So what we did in the city of Detroit, okay, so last year, the city of Detroit, we got over 16,000 mental health calls to 911. So in 2020, the chief of police, who is now, by the way, the CEO of our mental health board, but back then, he was the chief of police and he recognized this was a big problem. So he created a special unit of law enforcement officers that were specially trained to respond to mental health calls. And they did not show up in their police uniform. They had green khakis, or they looked like they work in the park. They had like green or brown khakis with a green shirt. They were very friendly looking. They didn't look like law enforcement at all. And they helped connect people to the resources that they needed in order to get better, okay? And they were trained that, people struggling with mental health disorders or addiction, this is a lifelong disease, right? And they might see these people more than once. We talk about in healthcare, your frequent flyers, whether it's to the emergency room where they're calling 911 all the time. Okay, so another barrier that we face is the funding. In Michigan, I can speak about Michigan because that's where I'm from, and I think it's like this in many other parts of the country. But in Michigan, our healthcare funding for Medicaid is split between, I'm going to describe it as neck up and neck down. You have your mental health, your behavioral health, intellectual and developmental disability. All of those dollars are your mental health dollars. They go into one bucket. And then you have your physical health care dollars that go into a different bucket. So you have two insurance companies, not companies, but you have two different buckets of money that are managing the person. It's one person, neck up and neck down. It's very hard to get coordinated. Sometimes it's difficult for the Medicaid health plans to communicate with the behavioral health plans. And the way they do it in Michigan is we get all the money from Washington, D.C. The state divides it by the geographic regions, and Detroit and the surrounding county that it's in, we get $1.16 billion of the mental health dollars. That's a lot of money. Only 0.5% of that is dedicated to substance use disorder. That's $6 million a year, guys, for Detroit and the county that it's in. That's Wayne County. So there, every time we have an administration change, people talk about we need to merge these two together because this isn't working. Well, I don't know. People talk about that every 4 years, and you might see this in the news. I don't think we should merge the two together, or maybe we should just provide funding to create more collaboration or coordination between the two, because when you have the plan funded at a local level, people can really get what they need, when they need it, and where they need it, which is home. Okay, it really should be at the local level. Financial reimbursement is like a big problem also. You have these misaligned incentives that may have created the addicted patient to begin with. This whole cascade of events that happened in the 2010s that kind of led us here. There's been a lot of documentaries on Netflix and movies everywhere about, how did we get here? The marketing from Purdue Pharma and all the different things, over-prescribing, over-dispensing. Oh, then you had law enforcement, the DEA, everyone. I'm not trying to point any fingers, but we kind of did this. Less pills became available, and then, with less supply, the demand didn't go down, so people turned to heroin. We started having fentanyl. It was kind of, we kind of helped create this mess. So we need to address it. The misaligned financial incentives, I want to say one more thing. I sold my pharmacies to CVS in 2017. So we were running these high-touch clinical programs in my pharmacy, especially the one for the addicted patients. That was a very high-touch program. We had, those shots take a few minutes to reconstitute, the naltrexone shots, and they're not easy, and it takes time. We had a special room in the pharmacy just for those. And in 2016, Medicaid decided they were going to pay pharmacies the net, cost of your drug plus $10. So they were calculating cost based on the national average drug acquisition survey that they were sending out to pharmacies across the country. And I only had 3 pharmacies. So the national average drug acquisition cost, okay, so you're comparing my purchasing power to Walmart and Sam's Club. We don't have that type of purchasing power at these mom and pop pharmacies, okay? But we were the ones providing these high-touch services. So cost plus 10 was actually below cost for a pharmacy like mine, okay? So these financial, this was a financial burden. And one day I took the numbers, I took the new formula, and I plugged it into a spreadsheet, and I realized that once this new this new reimbursement model was going to be implemented, we were going to have to let some people go. And that wasn't going to fly for me. This was a family-owned pharmacy. My kids ran around in the back. They were babies. I had my babies, not back there, but before they turned 6 months, they would spend a lot of time in the pharmacy with us. I like to be well-staffed in my pharmacy. I don't like to have 2 phones on my ear and trying to catch the drive-through and ring 2 people up at the same time, kind of what you might be seeing today in some of the retail pharmacies that you go to. And that's not why I went to pharmacy school. That's not how I envisioned myself helping people. So I made the very difficult decision to sell my pharmacies. Well, I just had to share that because it's a growing trend. A lot of pharmacies are closing now. Anyway, so you have these regulatory obstacles. I talked about the collaborative practice agreements. Some states are burdened by overly defined or overly restrictive collaborative practice agreements. Go back to your state. If you want to do something like this, take a look at your collaborative practice agreement laws and your public health code and talk to your legislator about it. Leadership can be overworked and understaffed, and sometimes we just don't have enough people to put these programs together, to create the collaborative practice agreements, to get people in the same room. So that's just another barrier that we are facing. Education is really the thing. I'm going to hammer in on this, Maggie. Thank you for giving everyone a little dose of it before I came up here. But really, education is going to reduce stigma among all the team members, okay? And it's going to help us see past our internal biases. I use the story of my cousin to show you that any one of us, anyone out there, can be experiencing negative attitudes towards these patients. I came up with this when I was in my program, and this is how I would try to recruit team members to our team. The education, this is the recovery house, the house of recovery. On the bottom, you have your foundation. Your foundation has to be strong education, which is going to reduce stigma, which is going to help you go to step 2 and recruit team members to your team. Not only do you need to recruit these team members, but you have to create a very good way for them to communicate with each other. And now it has to be, HIPAA compliant and everything, so people kind of struggle with, hey, should I use my personal cell phone to call the doctor about this or text them, or how am I going to communicate with the doctor about this? So you got to get your team members on board. You got to get a way to communicate with the doctor, the pharmacy, the patient, the nursing home, the nurses, the IOP, your recovery home. Only then can you start putting your pillars of your house up. The first pillar is collaboration. So you got your team members, now you can collaborate. But then your team members need to be fairly reimbursed for what they're doing, right? And then the technology has to be there for quick and easy payment that's clear, and for the communication. You really need the technology in order to communicate between the team members. Lastly, advocacy is so important. People need to know how to get the services they need and where they can get these services. And this has to be ongoing. You can't just do it for a month and that's enough, like a marketing blitz. No, this has to be ongoing. And the reason is because now at the very top of these pillars, I have a small step called patient engagement. So everyone has to be ready. We have to have all these pillars in place. Your team members have to be educated and ready to go. And when your patient who is struggling with a substance use disorder is ready, like the light bulb comes on and he's ready to go into treatment and he wants to quit drugs, he or she wants to quit what he's doing and he's ready to go. Most of the time, that light bulb comes on for them after they've had a dose of something, but then they're witnessing all the destruction around them, what a mess that they've made with their lives, and they realize, I really got to get out of this. That is a fleeting moment, guys. People don't stay there for a long time, because as soon as withdrawal starts to come in, as soon as the effects of their last dose start to wear off, they're back to trying to get their drug of choice. And then they're not going to engage with you anymore. Maybe they're gone for 3 days. You can't get a hold of them. So you have to be ready to get the patient when they are ready. And only with these things you can have long-term recovery. So I talked about how the pharmacist is part of the team through the standing orders, the collaborative practice agreements, and how we kind of did this was we had to get out of our comfort zone. Pharmacists are really comfortable in the basement or behind the counter. Get out of the pharmacy, guys, come on. Overcome your imposter syndrome, you can do it. I did it, and all it did was just kind of, sparking up a conversation with somebody. And I talked about how we did this over dinner a couple of times, and it was, and what I wanted to also say was when we had this program going, my staff was so engaged, guys. I mean, everyone came to work on time. Nobody called off. We were working towards a greater purpose, a higher calling. Everyone in my pharmacy had, including our drivers, had someone that was affected by the opioid epidemic, and they felt great about what we were doing. They knew no other pharmacy in Detroit was doing what we were doing. So it was a very nice time to be working at my pharmacy, and that was another reason why we were so sad when we closed it. Now here is a sample standing order from the World Health Organization. The standing order that I showed you earlier, that was one that we had created in discussion with the doctors, and I recommend, before creating a standing order or collaborative practice agreement, meeting with the team members multiple times, okay? Okay, so in the United States, we spend, this is the newest number, $4.9 trillion on healthcare every year. That's a lot of money. Now, in 2020, that number was 4.5. And there was a Senate committee that did a study or a report that showed that in 2020, we spent $1.5 trillion on the opioid epidemic. That's like 1 in 3 of our dollars. So we don't actually, I don't think, 4.9 trillion, I can't even imagine. We don't have a funding problem. We have a coordination and priorities problem. And I know that interdisciplinary teams can save lives and reduce costs. The CDC has a toolkit available on their website. I didn't post the link, but if you need a copy, if you can't find it, you can just Google this, but if you can't find it, just email me and I will send it over to you. I took this straight from the CDC's toolkit, and basically all it says is what I've been saying. Pharmacists are part of the healthcare team. They can improve medication adherence. The team is really the most important part, and the team-based care results in personalized, timely, and empowered patient care that facilitates communication and coordination among the team members. Here's an older resource that I used. I can't remember if I got this from APHA or where I got this from, but they list multiple disease states on here that you can use that you can address with a collaborative practice agreement. Sadly, addiction is not one of them. Okay, we need to add addiction to this list. Addiction is a chronic disease. This just came out. I just added this slide. The White House just identified their 6 priorities that they're going to address. And you got to go all the way down to number 5 to see where they say they want to provide treatment that leads to long-term recovery. I think we should move that up to number 1. Okay? Actually, maybe we could move prevention, which is number 4, up to number 1. And then number 2 should be treatment that leads to long-term recovery. But, over the past several weeks and months, we've seen a flurry of these executive orders addressing supply. And that's great. But we really need to address, prevention and building teams around long-term recovery. So living with a substance use disorder is kind of like being stranded in a stormy sea. It's a violent storm. There's cravings, there's withdrawal, they're experiencing emotional turmoil, crisis with their family or their friends or with their job. There's a lot of despair. And then when they're ready to seek help, they've all these obstacles, wait times, paperwork, maybe I'm not eligible, the insurance doesn't pay for this. There's no coordination between the physical and the mental health care providers and funders. There's stigma. They show up to the pharmacy or they show up to the doctor's office. Nobody wants anything to do with them. They don't want to treat them. There's so many providers that do not want to treat these patients. The team, the concept of the team, this framework that I'm proposing, this is the vessel that can lead somebody who is struggling with a substance use disorder to safe land. They can go from island to island on this boat, right? So the team kind of takes them safely around to the pharmacy, to the doctor, to the social worker. And there's so many, to peer recovery coach, they go to their meetings, they have to address proper sleep, nutrition, mental health habits. So it's really the team that is the vessel that is going to take the patient and lead them into a long-term recovery. So I told you guys I was really sad when I sold my pharmacies because I wasn't going to be on this team anymore. And so that's why I'm here. So I want you all to think about, what are you going to do when you go back home? It doesn't matter if you're a pharmacist, law enforcement, whoever. Everyone has a part to play. Maybe you can start a conversation with somebody. Maybe you can get things going. Who knows? My goal when I get home is to start a pilot. Actually, I've been working on this, and I've already faced a lot of challenges. The pharmacies that I'm approaching tell me, Ghada, we don't want to have anything to do with this. We don't want these patients in our living room, in our waiting room. Or some patients tell me, I don't want to keep those medications in stock. I'm in Detroit. We're going to get robbed. We get robbed all the time. Okay, fine. Okay, then they say, reimbursements are not working for me. I'm not going to lose money, Ghada. I'm already losing enough money. I'm not going to do it. Okay, so I propose to them, why don't we bill for the substance use disorder medication therapy encounter? There's a medication therapy management encounter that pharmacists can bill for. And their answer is, well, Ghada, it's a different software. You got to download it. It's something through the state. It's really clunky. I don't know how to do it. And then I found the pharmacy in Michigan that had the most MTM encounters in 2019, I think. I told him, hey, why did you stop doing MTMs? He said, oh, the state came and audited me. And even though they said I was doing everything right, it was such a pain in the butt to deal with these auditors that I decided not to implement this program again. And I was like, great, okay. So I have a lot on my plate when I get back home. I'm working on starting this pilot. What can you do? And I'm here for questions. I think I'm still okay on time. Does anyone have any questions? There's some post-test questions. Okay, so I didn't really show these earlier, but the number one leading cause of accidental death in the United States, does anyone know the number one leading cause of accidental death in the United States? Oh, the answer is A, opioid overdose. Okay, and potential members of the interdisciplinary team could be any one of these, right? So basically everyone here. So thank you for listening. If you this is my contact information. I put my cell phone up here. You can email me. Do you have any questions?
I do have a question.
Yes, ma'am.
Hi, great
Hi.
presentation, and something I'm very passionate about.
Thank you.
I have a question about, talking about the pharmacies and the community pharmacies and how important they are in solving substance use disorder. Do you think the new Pharm OUD guidelines that NABP, Tyler Briscoe, has put out recently will help with this?
The new MOUD guidelines? Mm-hmm. Yeah, definitely. It's something to follow. And it's a guide. Those are guides. You don't have, if you start up something with a physician practice, that's a guide. You can follow it 100% if you want, or you can modify it. It's really up to the physician that you're going to be working with and up to your state collaborative practice agreement laws.
And in addition to not just the barriers with doing the collaborative practice, but just carrying these medications in general. So he's also published some, stigma in the pharmacies and stigma with the pharmacists. Mm-hmm. Have you encountered that? And if you do you have a way that you educate the pharmacies on, kind of embracing the stigma and really trying to change that mindset?
Absolutely. In 2018, a patient overdosed in a CVS in one of the more dangerous neighborhoods of Detroit. And the pharmacist did not have Narcan in stock. It made it to the news, and they showed, people were in the aisles doing videos and posting it on social media. Sadly, the pharmacist had no idea what to do. He asked for water, and he was kind of putting water on the patient's face, and it was so sad that this pharmacist didn't have Narcan in stock, and he didn't know what to do. They ended up calling 911. They revived the patient. But after that happened, I worked very closely with the health department, the Detroit Health Department, to put on Narcan CEs, continuing educations, around Narcan. And then we further expanded that to include proper dispensing of opioids, and proper prescribing of opioids. So, it all goes back to education. So thank you so much for that question, because you're just reinforcing my point is to address stigma, you really have to educate people. There's not too many people who are willing to take this responsibility to go educate the healthcare professionals that don't have a clue, right? So thank you for that question. I hope I addressed it, but it's really just more and more education and changing people's attitudes, right? Are there any more questions? Yes. Yeah.
But, so, would you say that your pharmacy was the starting point for the collaborative agreement, and then from building your reputation, is that how you were able to get plugged in with state representatives and
Mm-hmm.
that's I think a big part of the issue too is the steps of getting to people who can help you create the change.
Absolutely.
Pharmacists
Yes.
Ghada, will you repeat the question for the people online to make sure they can hear?
Yes, absolutely. So she asked, how do you as a pharmacist get access to these people, like the state legislators, state representatives, or even people who are involved in the recovery community? Is that what you're asking me, right? Kind of? Okay, so the way I did it was just, I had to get out of the pharmacy. So I was always stuck between these four walls, right? But then when we opened more and more pharmacies, and I also attribute it to the fact that I was a working mom and I had babies, and once I realized I could leave the pharmacy, have my baby, and the pharmacy's not going to fall apart, I hired another pharmacist to go in there. I was free to go out there and do all this advocacy work, right? And so I got out of the walls of my pharmacy. I attended rallies. I was on the board for our Michigan Pharmacist Association, and then later on was appointed to the Mental Health Board for Detroit. And I would attend a lot of the addiction and anti-stigma rallies in our state capitol. And that is where I met the woman who has the recovery homes. Okay, she was standing there, and we were just I was with my daughter, and we were just talking, and she was like, "You're a pharmacist? Girl, come here. We got to talk. I've got my homes over here. I need some help. I'm going to introduce you to this guy."
Yes.
She goes and introduces me to the guy from Alchemies. And that's how we got into, okay, he's like, you guys want to talk to Dr. Fox? I'll buy lunch, dinner for you guys. We'll bring all your teams together. And that's just how it happened. It was just like, just standing there talking to people. And I also met the OB-GYN who was in charge of, there's one OB-GYN for the whole state of Michigan that deals with maternal patients who are addicted and pregnant. And I got to meet him too. My sister's an OB-GYN, and I kind of made that connection with him. It was amazing. The recovery community is very large, and you really kind of have to get uncomfortable, get out of your comfort zone, overcome the imposter syndrome. You could be standing next to the person that you want to talk to. Just strike up a conversation. You never know what it's going to lead to, right? Thank you for that question.
Anything else? Anyone else? All right, thank you so much, Ghada.
Thank you.
All right, if y'all would take a 10-minute break and be back, we'll do a few raffle items.